Right. Okay. So, friends, we are here again live for the 2022 IOA webinar on rheumatology. And we have again the distinguished teaching faculty. And without wasting any time, I would like to request our president, Professor Ramesh Kumar Sen, to say a few words. And only few days earlier, I have seen his presidential motto that success with surgical and soft skills. So I will be happy if he throws some light on his topic. Professor Sen, please.
Success with surgical skills.
Right.
So, 101 कहाँ पर है? 101.
Professor Sen, are you there or we have missed you?
Let me welcome all the participants. I think this, I'm very glad that well in time, first of all, and this is something which is most active kind of a group which has come up. And I'm really
101 कहाँ पर है? 101.
fascinated
Yes, please go ahead.
by the organization of a beautiful educative program.
You can put your video off and then perhaps the audio will be more clear.
Which the last time I attended, I could attend it fully and learned a lot many things. And product-wise progression, we are able to give a way to interact it, and an area in which, as a general orthopedic surgeon,
Perhaps we are losing connectivity of Professor Ramesh. Till the time we can get reconnected to Professor Ramesh, I will now request our IOA secretary and a learned faculty himself to kindly address us for inauguration of this second rheumatology webinar. Dr. Naveen, please.
Yes, sir. Yes, sir. Now Dr. Dilip sir is also with me here.
Okay,
so he's with me in the 101 room at Daugar. So we welcome all the got special appreciation, presidential appreciation award for its activity during the last year. And this year also, this committee is leading with a very good program and innovative ideas of having a very good webinar. Without wasting any much time, I would like to say that please start your academic program, and we wish all the success of this committee and all the webinars and academic work, sir. Thank you, sir.
Thank you,
Dr.
Professor
Dilip
Naveen.
Majmudar, sir, is here. You can speak here. You can speak. Your voice will go, sir.
Hello.
Yes.
Hello.
Right. Please
Hello.
go ahead. Yes, yes.
Can you listen me?
We can listen to you very clearly.
Right. Welcome all of you. And there is a resounding, sound is resounding.
Just because you are here.
Yes.
Sorry, sir.
So we get a green signal from your end also, because the sound is really broken. We have again got reconnected with Professor Ramesh. So Professor Ramesh, your few lines, please.
Ramesh Sen is there?
yes. So
Yes.
yeah. So I was talking about that with this group, we have been really very happy, the kind of a program it has been started, and the medical management, which is a very important part in our day-to-day practice, especially in a office practice kind of a disease. which is very good. And so that way, I think it's a very good start. I congratulate the organizers and I wish the success to this group's work in IOA.
Right. So we can go ahead. Professor Ramesh, Dr. Naveen. So
Please.
friends,
Yes, sir. Yes, sir. You can
Yes.
go ahead, sir, with the academic
Okay.
activities, sir. Yes, please.
right. So friends, we have only during the last webinar talked about early detection of rheumatoid arthritis. And see, so the principal goal of management of rheumatoid arthritis is what? Achieve sustained remission or minimally produce low disease activity. A most acceptable term has been coined pre-rheumatoid arthritis, and it is coined for evolving stage of rheumatoid arthritis even before clinical appearance of the disease. Unfortunately, this is labeled only retrospectively many a times. Friends, whatever transpired during the last webinar, here we have Professor Abhay Elhens, who is heading the Department of Orthopedics at AIIMS Jodhpur, and he will be telling us the lessons learned from rheumatology early detection. Professor Elhens, please. I will stop sharing.
Good evening, sir. Thank you very much. Can you see my screen?
Yes, very clearly.
And can you hear me, sir?
Yes.
Thank you so much, sir. Dr. Jha, sir, Dr. Sen, Dr. Naveen Thakkar, sir. Coming to the topic, my brief is to talk about the lessons learned from early diagnosis of rheumatoid arthritis. So the question is, why do we need to learn lessons? And the answers obviously are that it is important to decrease the burden of rheumatoid arthritis. It is important to try and reduce disease progression. It is important to cease patient deterioration who are patients of already existing mono, poly, or oligoarticular disease, and to reduce the role of a rheumatologist by preventing extra-articular manifestations. And the important bit is that the disease may need prolonged drug therapy, and that itself can cause drug reactions in the long term, which needs to be scrutinized. So why medicate if we can prevent? And what are the lessons learned? The most important ones are preventing progression to severe RA by identifying pre-RA, as Dr. Jha mentioned. And how do we do that? By early diagnosis, which is either serological or clinical diagnosis. And early diagnosis essentially leads to early treatment and a predictable remission of disease. And very important bit is to identify the different differentiating disease entities which may mimic rheumatoid arthritis, and also to identify the different variations of the disease by which the disease may prevent. So what is pre-RA? Well, before we have a patient with an established rheumatoid arthritis, the disease essentially walks through a couple of stages or phases. And those include a genetic and an environmental predisposition with risk factors for rheumatoid arthritis, which is to say that there are at-risk individuals for rheumatoid arthritis. And when they undergo a transformation of the autoantibodies, they develop a stage which is symptoms, where we see symptoms without really seeing a clinical evidence of arthritis. And this essentially goes on to an undifferentiated arthritis or a palindromic rheumatism, and which will later on cause established rheumatoid arthritis. And it comes to reason that if we can stop, prevent, or identify a disease before it goes into an erosive or a destructive form, then obviously we are looking at earlier diagnosis, earlier treatment, lesser complications, lesser disease load, lesser disease adverse drug reactions in treatment of disease. So the risk factors for rheumatoid arthritis, well, there are the genetic factors, which include the HLA-DR4, which creates a 4 to 5 times increased risk, and several protein peptides, such as the PAD1 and the PTP22. And of course, there are the environmental risk factors for rheumatoid arthritis associated with a systemic autoimmunity associated with RA, and symptoms without clinical evidence of arthritis and early indifferentiated arthritis. And the environmental factors essentially include smoking, viral infections, dietary factors, hormonal factors, and obesity. Now, what is important is that once a patient develops undifferentiated arthritis, it could have 3 different course of events. And those course of events are essentially that the disease could go into remission, which is about 30 to 50% of the times, or that the disease may persist as undifferentiated arthritis or progress to other diseases, which is also a 30 to 40%. And about 20 to 40% will actually develop full-blown rheumatoid arthritis and an erosive variety of disease. So how do you predict? And there is a beautiful Laden's prediction rule, which says, which basically predicts disease outcome in patients with an early onset undifferentiated arthritis. And the key factors that these Laden's rule use is that there are points given for every different symptom of every different risk factors, which add up to a certain number. And based on that number, one can identify how the disease is going to behave. So if one looks at the age, the gender, the joint distribution, presence or history of morning stiffness, tenderness of joints, swollen joints, CRPs, RF positivities, and ACPA positivity, we get a certain score. So if the score is less than 6, 91% of these patients will not progress to florid RA. If the score is more than 8, then 84% of patients will progress to full-blown rheumatoid arthritis. And somewhere is a score between 6 and 8, where the disease cannot be predicted to go either towards full-blown RA or towards not progressing to RA. But still, if we have a score, we have an idea where we are going with the disease symptoms and the disease onset. So the early diagnosis essentially requires screening of the first-degree relatives of rheumatoid arthritis patients to identify autoantibody positive individuals. And this, we understand that twins of rheumatoid arthritis patients have an additional 12 to 15% risk of developing full-blown arthritis. And the non-identical twins have about a 4% incidence of developing a full-blown arthritis. And therefore, we come to the autoantibodies or biomarkers other than the rheumatoid factors and the ACPAs, of which we have the anti-MCV, which is associated with a more severe form, a version of disease, the 1433 eta protein, anti-CAR-P, and the COMP, calprotectin, and survivin, which are tumoral biomarkers present in rheumatoid arthritis. And these essentially also have a role to predict the response and the behavior of disease to certain biologic agents, which may need to be used for aggressive or angry form of rheumatoid arthritis. Certain radiologic investigations, such as the TC3PR-GD2 scintigraphy, have been known to identify and help in early detection of disease as well. And there are certain reasons why we want to do an early detection. Early detection, because early detection provides a window of opportunity for early treatment. So if we have a patient who has an anti-citrullinated protein and autoantibody positive, the ACPA positive individual, then it takes about 12 weeks, slightly less than 12 weeks for this patient to develop full-blown rheumatoid. Or if it is an ACPA negative individual, it takes about 15 weeks to develop irreversible or full-blown rheumatoid arthritis symptoms. And therefore, it is important to know which phase of disease is the patient in, because it helps us to intervene accordingly so as to prevent irreversible joint damage. The importance is that treatment initiation in the first 12 weeks, if we do an early detection, is particularly effective in controlling disease activity. And these are the patients who will have a better midterm as well as a long-term outcome. For example, the FINRACO trial demonstrated that if we have a delay of about 4 months, and the only significant predictor of remission was the single DMRD strategy, then a delayed rheumatology reference of about 12 weeks essentially causes a 1.3 times higher rate of joint destruction over 6 weeks. And you have an increased incidence of erosive arthritis, then we are looking probably at a very aggressive medical treatment as well as surgical treatment for joint destruction. So there is basically an essentially an algorithm or a flow diagram which talks to us about why early detection. Because if you look at early detection, it is basically to identify and look at targeted activity, where it is important to see if the disease activity is low or high. And then we identify whether the features, what features of poor prognosis are present. And based on that, you can give a targeted therapy of a DMRD monotherapy, or a combination DMRD therapy with double or triple agents, or a DMRD monotherapy with HCQS and methotrexate, or if the patient needs biologics. So a targeted therapy is important to identify and initiate. And for that reason, it is important to identify early disease activity. What is also important to understand that we need certain markers which will help us to predict the kind of remission a particular patient will go into. And there are certain factors which may be responsible to predict which are the important events where the patient may go into early remission or may cause a delayed remission. And of them are the disease activity scores, the VERAs, and basically the DMRD requirements in the first 3 months of initiation of therapy, which is very important to diagnose and identify which patient will go into remission and which patient will not. So the principal goals in basically the management of rheumatology essentially is addressed, because we are going to do early detection, and that helps us to undergo therapeutic intervention at an earlier stage, which leads to aborting the disease, achieving early and sustained remission, and minimum to provide a situation with low disease activity. The other and the last part is identifying the variable presentations and the disease mimickers for rheumatoid arthritis. So a polymyalgia onset, or a palindromic onset, or a systemic onset, or a persistent monoarthritis, these are the different variable rheumatoid arthritis presentations, and all of these have to be identified in terms of disease activity and the presence of autoantibodies, and then we can predict which ones will behave in which fashion. The other thing to identify is the diseases which can be called rheumatoid arthritis mimics, for which you could have post-viral arthritis, connective tissue disorders, inflammatory osteoarthritis, crystal arthritis, and certain miscellaneous diseases such as sarcoids, thyroids, infective OHSU, and paraneoplastic syndromes. So the future, well, it is a new subject. Research in early diagnosis has long-term financial implications, and it certainly has an effect on the human body based on whether a person is a responder or a non-responder for early treatment initiation, and certain biomarkers and investigations are extremely useful in all cases of inflammatory arthritis. So to summarize, why early detection? It is important because we need to prevent patients with risk factors for florid disease. Why early detection? Because certain RA patients can be seronegative. Why early detection? Because we need to identify those who are in pre-RA situation of disease, which may lead to progression. And why? Because if we fail to do so, we miss the 12-week or the 15-week window of opportunity, and we should not refrain or miss out on looking out for diseases which mimic rheumatoid arthritis or variable presentations of rheumatoid arthritis. Thank you very much for your time.
Thank you, Abhay. You have come out with a very good lead-in prediction rule that which patients are likely to develop into fully blown rheumatoid arthritis. Well, just a minute. So the principal goal of management of rheumatoid arthritis, once again, and you have rightly emphasized that diagnosis of exclusion where involvement of more than monoarticular affection unfulfills the criteria for diagnosis of rheumatoid arthritis, there they have potential for development of persistent inflammatory arthritis. And as you have rightly said, there are high-risk persons developing rheumatoid arthritis in future, and they should be looked into. All the first three points you have already said. And the fourth is, if at all screening is viable, it should be done in a population with high disease prevalence. So the advantage is, as you have rightly emphasized, that it evolves into a management program where the disease can be arrested or aborted even before it becomes clinically evident. Symptomatic patients required to be managed effectively with early achievable remission or low disease activity. The management you have outlined, and it will be detailed later by me also. Now, Pannak Bhushan, you are not there? Okay. So somehow he is there in the Devghar conference of Jharkhand Orthopedic Association, and he has not been able to connect with us. Friends, his topic is two-step diagnostic strategies in rheumatology. Let me very briefly tell you what these two steps are. The first step is define generic type of pathology. So when we are talking to the patient, and as I have told you, that always talk to the patient till the patient gives you a diagnosis. So first step is define generic pathology, design your initial interview, establish main syndrome on pattern of symptoms. Regarding one of the pattern of symptoms, Dr. Amarnath is going to speak on neurological symptoms. Must determine existence of typical features of a given or disease or distinguished from others. Do not delve into too much of detail. No impact on objectives will be there. Be precise in details. Let them be very decisive and identify by rule of exclusion. So in rheumatology, if you pinpoint that he is going to be a rheumatology patient, the basic symptoms are related to anatomical landmarks, and the source could be articular, periarticular, muscular, or systemic. So the first goal is get to the right neighborhood. Suppose we have gone to a new town and trying to locate the exact address. So we are trying to reach the best known neighborhood first, which is not too far from our final diagnosis. So first step is differential diagnosis, which should be familiar with main syndromes. And step two is, after arriving at a particular set of symptoms, joint disease, generalized pain, bone pain, proceed to detailed investigation to delineate the conditions.
Yeah, thank you.
This is the second step in differential diagnosis. So these two are so very important. Now there is a word. Create a magic of 10 words while you are taking the history. Like, describe your patients with as few accurate and possible, as a rule, will not need more than 10 words. So within 10 words frame, you try to make up the whole story. Like example 1, young man with inflammatory back pain, no systemic features. That's it. And then you proceed for further differential diagnosis. Another example, woman with symmetrical, additive, chronic, persistent, peripheral polyarthritis with no axial involvement. So try to make a brief within 10 words. Third, generalized pain with no objective findings. So that should form the basis of two-step diagnostic procedure. Friends, now Jogesh is there, Dr. Jogesh Kamath from Mangaluru, and he speaks on crystal arthropathies, introduction to early detection. Dr. Jogesh, please. I will stop sharing. Yes, Jogesh.
Thank you very much, sir. It is, again, a privilege to be part of this. And greetings to everybody from Mangalore. So I am going to be spending the next few minutes on basic clinical pearls in crystal arthropathy. So I will focus mainly on clinical points of relevance to every orthopedic surgeon. The mainstay of this is obviously going to be gout, but I feel all of us, even though all of us singularly, each and every one has seen and or had an opportunity to treat it, a lot of treatment for gout and this kind of inflammatory arthropathy still remains far from ideal. Now, let us start with various crystals which can be seen in the synovial fluid and can cause a problem, as in inflammatory arthritis. The major chunk of this, of course, is urate crystals, which cause gout, and what is sometimes thought of as gout, but does not behave quite like that. And the crystals are different, hence we call it pseudo-gout. Just for the sake of mention, the rest of those crystals are indeed very rare in causing arthropathy, but we have to complete a list there. The third in line, of course, is calcium oxalate crystals, but occasionally cholesterol, steroid, and lipid droplets, including talc, can cause problems. So now, again, we come back to the mainstay conditions, that is gout and pseudo-gout. So what happens essentially in these is, what can be absolutely diagnostic and unmistakable in gout is these tophi, which you see deposited particularly on the hands and feet. They can be asymptomatic or they can be associated with inflammation and pain in joints, particularly very, very acute painful episodes. Now, pseudo-gout is usually more chronic, but can also present with acute features. The classic X-ray signs of gout are, like you can see here, extra-articular scalloping and soft tissue deposits, which can be seen in the tissues. The most clinically involved joints in gout are, again, hands and feet, but that does not go to say that other joints do not get involved. The knee is obviously very commonly involved in both. Now, talking about features of one against the other, both are obviously inflammatory. The difference in gout, of course, and the reason why we are stressing on gout again and again is because it's far more common and it can be treated very easily, unlike the other ones. Now, gout is predominantly in small joints, whereas pseudo-gout need not be. Gout can also involve the large joints. Again, both of these, even though they present, or gout rather presents as acute inflammatory episodes, they can have an acute and chronic and also a chronic picture as well, which increases with secondary arthritis over time. Now, the key thing to understand in differentiating and diagnostic is if you have tapped a synovial fluid. Now, this is a common situation. I'm going to talk on relevant clinical pearls here. The common situation we get is a flare-up of an inflammatory arthritis in the knee, and we all have faced it at some point. It presents often like a septic knee. So we end up tapping the fluid, and the diagnostic thing here can actually be examining the fluid under a microscope. Now, to see it under microscope, what you need is a polarized light microscope. It is not a very expensive thing. It is just having a light axis in a single line in the microscope, which unfortunately many well-marketed labs don't have in our country. It is very simple to even the untrained eye. If the crystal is along the line of the polarized light, it is called as positively birefringent crystal, which is characteristic of gout. If it is not along the line, it is a negatively birefringent crystal, which is of pseudogout or the others. So gout is very, very diagnostic under a polarized light microscope. The treatment covering is not a part of this lecture, but I will talk about some basic things which are important in diagnosing and treating it properly. So everybody commonly believes that gout is associated with a high uric acid level. Now, to a large extent, that is true because primary gout essentially is the body not being able to metabolize uric acid, but a uric acid level being high does not go the other way around, does not diagnose gout. Particularly in an inflammatory episode, mind you, a uric acid level is very, very likely to be normal. So please avoid making fast conclusions. One of the most important things to learn, that's why I put it in a lighter vein. All of you might get very excited looking at this, but take your time and decide before actually drawing conclusions like you can draw with uric acids in gout. So the diagnosis, again, should be clinical. The bottom picture where you see a cellulitis, an infective type of differential diagnosis, is always likely to be an acute attack of gout, which need not be treated with antibiotics, but just anti-inflammatories. Now, what you see at the top is the extra-articular tophi, which will happen with a more chronic kind of existence, by when the diagnosis is obvious, but we're just basically talking about being able to make a diagnosis early. So, clinical features, acute or chronic, most important, I've talked about that already. Gout very often presents as just a single joint being involved. The common is the thumb, or the commonest, the ball of the great toe, again. But like you've seen here, again, with evolution of the disease, it can be polyarticular. An important point here, take it as an unwritten rule out there. Women who are in their menopausal years will, by some protection given to them by their female hormones, not develop gout. So if you've made a diagnosis of gout in a woman of childbearing age, you are quite likely to be wrong. Reconsider your diagnosis. The disease evolves with time, and we've had such a beautiful lecture from Dr. Abhay on how different inflammatory and rheumatoid diseases can evolve. So again, the next and most important thing to remember is the gout primary or is it secondary? And this is why I would say don't hesitate, don't start treating without evaluating other medical features. A lot of things, including chemotherapy, systemic disorders, hematological disorders, drugs given to control hypertension, kidney diseases, and obesity, alcohol, etc., can make for decreased metabolism of uric acid in the body. This is not primary gout, this is secondary gout. So this does not require the traditional treatment for gout, but actually management of the parent condition and or change of treatment accordingly. Again, counseling the patient if they are on chemotherapy that they may develop this kind of symptom is important. Now, Gout and uric acid levels is what I was talking about before. Uric acid levels will not be high during inflammation. Again, if you're making a diagnosis of another inflammatory disease, it may not be gout, because two inflammatory conditions can almost never coexist. Remember that. Again, if the person is having a gouty acute attack, do not treat with allopurinol. Allopurinol is only something to prevent an attack from happening, and if given during an acute attack, it can actually precipitate and make it worse. So beware of this, which often happens to be a mistake in clinical practice. So to summarize, there are different features which look attractive or throw up surprises, but there's always a way to get around those surprises. So go by basic clinical features, go by the basics, and you will hit the nail on the coffin. To summarize, clinical evaluation is diagnostic in crystal arthropathy. Blood, the inflammatory markers just tell you as a basic thing that you should treat acutely and with anti-inflammatories and not with allopurinol. Repeat uric acid levels. If you're in doubt, don't believe a single high uric acid level. In a clinical situation, effusion can be done with a proper aseptic aspiration, and a good diagnosis can be made to treat the patient confidently and unnecessarily avoid treating a septic arthritis with surgical washouts or antibiotics, as often happens when an acute attack of an inflammatory nature is misdiagnosed as septic arthritis. And do not hesitate to get a thorough medical evaluation from a medical colleague. Thank you. Thank you very much.
Thank you, Dr. Jogesh. You have been simply wonderful, and you have been rightly talking about that ladies during their menstrual cycle, they do not get raised uric acid. The answer is only that estrogens, they are better promoters of urate clearance from the kidney. So that is the only reason that ladies during their menstrual cycle do not get it. But there can be exceptions to the rule when an active menstruating lady can still get it. And then you have to look into the renal function, whether there is some genetic fault with the renal filtration, or the patient is on antihypertensive, and so on and so forth. Now, you made a statement that two things do not coexist. And you rightly said in a way that gout should not be overridden with rheumatoid arthritis. But I have looked into the literature. Though the world literature only finds less than 100 number of cases, but there are minimum 100 cases reported, documented, who had both rheumatoid arthritis and gout. So what are the predisposing factors? You said, all right, obesity is one. So elderly, male, obese, and either he or he was suffering from rheumatoid arthritis or gout, he can get the other one as well. So you have to be cautious in this age group. Now, one thing more, dual energy CT scan in 2017, they came out that this dual energy computerized tomography, that is CT. So if you go for using this one, uric acid deposition will be found in most patients with even RA. So that means we are really missing many patients who are being treated for rheumatoid arthritis, and such uric acid depositions can be seen in dual energy CT scan. So this one investigation we orthopedic surgeons must look into, and dual energy CT scans are available in your town. Now, as you have rightly overemphasized that aspiration must be done and demonstration of urate crystals under light microscope, polarized microscope, and as is being seen here, and you have also shown, they can be seen as the monosodium crystals. Another important thing is, if you perform ultrasonography, there is a double track sign of the articular cartilage. Now, this again is very important, that the articular cartilage, so the joint should be submitted to ultrasonography, and there has been a lot of work on ultrasonography in rheumatoid and gout also. But if you suspect gout, please ask your ultrasonologist to look for this double track sign, which is a typical characteristic image in gout. So that's it. And
so I want to
yes,
have
please,
one comment here.
Please.
So one wonderful lecture by Dr. Yogesh. I just want to re-emphasize one important thing to all audience, to all orthopedic surgeons who are listening to it. Until you are able to demonstrate the crystal has been emphasized here, please don't label it as a gout. In all other condition, any inflammatory marker, any inflammatory features which are there, they show and to be labeled as a hyperuricemic condition. So gout should only be told and required to written down if we are able to demonstrate the crystal. That is why most of the time, if you see rheumatologists and other prescription, we don't have as we already mentioned, that we don't have so much polarized microscope in our country. So that is why, unless until the picture is very clear, it should not be labeled as a gout. Most of the time, the symptoms as overlapping symptoms, because of so many, like rheumatoid patient, many rheumatoid patient, because of systemic involvement, they have a hyperuricemic state. And unless and until you are not going to manage that hyperuricemic state, the disease is again not going to settle down. So it is a side-by-side journey of a uric acid examination in all the rheumatoid patient or all the spondyloarthropathic patient to hit the nail. That's
right, Manish, you have rightly pointed out that hyperuricemia could be asymptomatic, but when it becomes symptomatic, this will have to be taken into consideration. One, you have already pointed out, demonstration of those crystals. Number second, I have said that typical presentation in ultrasonography, and with advent of dual energy CT scan also, they can be seen. This topic was very thoroughly discussed in one of the American academy, and there a group of surgeons said that the crystals that you are claiming to be crystals of uric acid, so they are cholesterol crystals, and Dr. Yogesh has talked about presence of cholesterol crystals. So you are right, Dr. Manish, that there can be a confusion even with cholesterol crystals and maybe other crystals.
But most of the time, they are the very established crystal, as I mentioned by Dr. Yogesh. They are very particularly easily diagnosed by polarized microscopy. And if they are visible, they are thought to be uric acid crystal most of the time.
Well, I had a research topic on intra-articular hydrocortisone, and I have dissected those experimental knee joints and could see that steroid crystals which were injected are also many a times found. So the list submitted by Dr. Yogesh had steroid crystals mentioned also. Okay, friends, now it is turn of Dr. S.S. Amarnath. He talks on approach to patients with neuromuscular symptoms. Dr. Amarnath.
Thank you, Dr. Jha. I think I'll wait for you to
stop sharing.
Yeah, thank you.
No. Yes, please.
Thank you, sir. I think basically the topic is going to be very, very clear, what I've said, and I'm going to be talking about, just a second, I'm going to share. For some reason, I'm not able to see the share button. Okay, now. Okay, great. Here we go. So what I'm going to do is just a minute. I'm going to put my marker here, and I'm going to share the screen. And I'm going to come on to PowerPoint presentation there. It's coming on PowerPoint presentation, sir.
Yes.
Full screen, great, wonderful. So we are good to go, and I'm putting my timer as well. So it's not easy to compile everything, but the key points we will highlight, and obviously it's going to be the biggest thing that we can share the knowledge and give the key pointers so that the audience and the delegates and the observer can pick it up. And it's a privilege, and I cannot say no to this. And then absolutely thank you for the committee and Dr. Jha and IOA to having this platform. I think Abhay has already given the evolution of the disease, and then we're going forward, what can be done, and the crystal arthropathies have been picked up. And then absolutely, I think none of us want to have any painful joints. I mean, that's basically understandable. But this also can coexist with a patient with a neuromuscular symptom. That is the biggest issue. Now, I will not be talking much on the rheumatoid arthritis or any other arthritis, but definitely touch upon back and forth. But let us understand the neuromuscular symptoms, how and where we can take it forward. How do we approach it? So examination, like Dr. Jha said, and all our training, we have understood that we have to listen to the patient. History taking is the most important thing. I'm going to highlight that again. And then comes your examination. Before that, whatever points that you and I need to ask is the biggest thing. First is listen, 100%, and then you evolve in terms of taking the key forward to ask till we are satisfied that yes, we can come to a conclusion. 90 to 95% of diagnosis is made there. Taking it forward, that is the main thing. Localize it. So that's what I'm talking about. It could be drug induced, it could be anything. I'm not going to be reading the slides here. Just a minute, I'm going to minimize here. It's all coming in the way for me. Okay, great. So with that in mind, I think we need to move forward. And high suspicion in young people with rheumatoid has to be kept in mind. And obviously the differential diagnosis of all the other variety of rheumatoid has to be kept in mind. Now, the neuromuscular symptoms can be early or can be late as well. So we need to differentiate that. And many a times with the kind of comorbidities and the rheumatoid arthritis, many of them would have had glucocorticoid steroids. That causes huge amount of challenges there. And obviously we don't need to worry about the contractures and things like that because that's already there. But you need to look at why the muscle atrophy is happening. Is it due to the rheumatoid arthritis, or is it coming on from the neuromuscular challenges? So that's where the whole thing comes into. Obviously, we all know that pain, muscle atrophy, altered sensation, and fatigue and malaise, we need to be very careful how to differentiate that. So again, fatigue and malaise can be a part of so many other conditions, nutritional, and off late. I mean, we've been talking about osteomalacia for the last 35 years. It's only off late that government of India and the surgeons and the doctors alike have opened their eyes up for osteomalacia. So that is the biggest thing. And hormonal. Sleep has to be picked up in mind, has to be a good amount of sleep. And poor physical condition of hygiene, and a lot of things can be talked about. Chronic inflammatory disease, not just related to your joints, but per se the whole. Systematically, we can look into that. So let us talk about it. How do we categorize it? Where do we go? Spinal cord, is it coming from the nerve root, or is it peripheral nerves, or is it from the neuromuscular junction, or the muscle itself? So this is a beautiful chart which gives you the differentiation from the spinal cord involvement, or is it from the vascular, or so many other challenges. It could be drug induced as well. So just take that cue and then make sure that I emphasize that here to categorize that, very, very important. Then comes the lesions of the spinal cord is very important. In the spinal cord, what happens, the lesions can be painless many times. And obviously extensor and flexor muscle spasms sometimes coexist depending on the kind of lesions. If it is a nerve root compression, then paresthesia is biggest thing. And obviously, in ascending, it's a different kind of symptom, but that need to be kept in mind. Inflammatory, obviously painful, not as much, but sometimes in a fulminant variety, you may get severe pain. Muscle pain could be vascular insufficiency or disease from the muscle metabolism. So myopathies could be symmetrical, asymmetrical, upper limb, lower limb. We can go on and on. And again, in spinal cord lesions, we need to talk about the trunk and abdomen and bowel bladder which is going to be there. In Guillain-Barré, abrupt onset happens in polymyelitis and hypokalemic periods as well. In the intermittent, weakness can be picked up in myasthenia gravis, and the gradual onset, most muscle diseases comes from the endocrine or the inflammatory, and it could be basically primarily from muscle dystrophies. So this is the biggest thing. You and I need to make sure that we need to help them. So today I will not be talking about the treatment nor the investigations, but things I'll touch upon there. Fatigability, we have to clearly differentiate. Very important. And many a times we have seen in a rare maybe where with repeated muscle action, there could be an asymmetric muscle mass development. That is Lambert-Eaton myasthenic syndrome. Just keep that in mind. Very, very important. In the family history and in inheritance, we need to look at, it could be, linked with, or it could be autosomal recessive or a dominant kind of a variety of inheritance that we want to pick up. And the precursors are going to be hormonal, maybe drugs, many drugs from glucocorticoids to statins. Many of them are there. And Yogesh talked about colchicine. And in rheumatoid arthritis, the first line of DMARDs come into picture as well. So hydroxychloroquine is one of the things. And then today, I think the dermats, a lot of people are using antifungals. We need to be careful about them. And thallium, arsenic are very rare. So let's not pick up that. This is key important factor. You and I need to not just look at the joint, but the whole patient per se, the wholesome approach, the holistic approach, whatever you call it. So that needs to be looked at from every system. Then obviously the joint affected, then the muscles, the groove, the girdle, or the limb, we need to look at that. And then, pick up all the details of the strength. We need to grade the strength of the muscles where they are, either from 0 to 1, 0 to 5. And then apart from that, even in the DTR, we can grade them. Very, very important. Deep tendon reflexes can be graded from 0 to 4. So make sure they're all coming under the 2, the mid pathway, the number 2. So keeping that in mind, screening is extremely important. Again, in the signal, we can have a signal which could be exaggerated, or it could be slow. So sluggish, or many times it could be absent. You need to pick up each and every of that and then make sure that we do not miss that. And in certain biology, the examinations biochemically, these are the things which can go up and down. We need to keep in mind. And mind you, intramuscular injections, sometimes the crush injuries also causes some of the changes there, and myocardial infarction, and particularly in Caucasian countries, when you pick up Afro-Americans, they seem to have higher creatine phosphokinase. So that's going to be there. So other tests I'm not going to dwell into. There are a lot of things that you and I do. So specifically, we need to look at that. And common causes of the weakness, we need to be clear on that. Fibromyalgia, it could be myalgia rheumatica or polymyositis. It could be corticoid myopathy as well. And hormonal, you and I know that. So keeping that in mind, I'm going to give a compiled one. Obviously, the take-home message for each of us is history taking is important. Localize the entire symptoms by clear-cut examination, and make sure that it is differentiated. But mind you, just because you and I don't have the symptoms like what Yogesh was talking about and Manish was talking about, in last sentences is, if you and I have one particular condition of immune system which is deficient for us, autoimmune deficiency coming into, secondary can be there as well. So it could be hormonal, it could be drug, it could be many things. So it can coexist. So do not neglect, examine, make sure that we don't miss it, pick it up early so that we can treat early. Thank you.
Thank you very much, Dr. Amarnath. You have rightly enumerated all the linking points between neurological symptoms as such and neurological symptoms related with rheumatological conditions. So, if we find a patient of even stroke in young adult, it should raise diagnostic suspicion of a rheumatic cause, and the conditions could be even like SLE, antiphospholipid antibody syndrome, polyarthritis nodosa, Takasai arthritis, Wegener's polyangiitis with granulomatosis. Friends, we have also to be conscious of a very common drug, these statin drugs. So they can induce myopathy and they can present with myalgia. So we have to be conscious about this very common drug also. So what suggests neurogenic pain? I would further like to say that look into the nature of pain. Is it dysesthetic? Most common sites, sciatica, carpal tunnel syndrome, ulnar syndrome, and so many other associated neurological compression syndromes. Exacerbation of the pain with Valsalva maneuver, very common maneuver like in radiculopathies. Exacerbation with mobilization of the spine like in radiculopathies, and tenal sign always we can decipher. So for any peripheral or central nervous system association, dysesthesia, weakness, convulsions, alterations in behavior are so very important. Well, Dr. Manish, if you permit me, I will proceed with this presentation.
Sir, please, sir.
Okay. So the topic of presentation is management of early disease of rheumatoid arthritis. The basic baselines have been drawn by Professor Abhay. Friends, early rheumatoid arthritis preferably means a disease duration within 6 months, but preferably 3 months. Ideal treatment target is remission, and a remission which qualifies sustained drug-free remission culminating into persistent remission, or at least low disease activity. Well, friends, as already discussed, this early detection provides an early window of opportunity. Now, what is there in our armamentarium to treat rheumatoid arthritis? We are surgeons, and when we plan a surgery, we select our instruments. So similarly, the instruments in our kitty, they are NSAID to start with, maybe till the proper diagnosis has not been made, or just to curtail the pain feeling. The most important is anti-rheumatoid drugs, which are basically disease-modifying anti-rheumatic drug and adjuvant drugs like glucocorticoids. Now, whatever drugs are available, they are all disease-modifying anti-rheumatic drugs. So, non-biological, they are methotrexate, hydroxychloroquine, sulfasalazine, L-defnumide. They are targeted synthetic like tofacitinib, baricitinib, upadacitinib, and there are biological also, which goes by the name BDMARD, and there are biologics which are TNF inhibitor, and you can classify them into broadly into non-TNF inhibitor. So after this, the conventional synthetic DMARD therapy can be either used as monotherapy, dual therapy, or triple therapy. So what are the kind of patients presenting to us with early rheumatoid arthritis? These are the patients who have not been treated earlier with DMARD. So they are DMARD naive patients. So I have tried to formulate the Indian Orthopedic Association guidelines for rheumatoid arthritis therapy. And number 1 guideline is low disease activity patient. Prefer hydroxychloroquine as the first choice. Prefer sulfasalazine over methotrexate. And finally, mind you, this is all for low disease activity. Lastly, go for the golden drug, methotrexate, and prefer this one over leflunomide. Now, guideline number 2, if there is moderate or high disease activity, you can start your monotherapy, and here you prefer methotrexate monotherapy over hydroxychloroquine and sulfasalazine. So low disease activity, prefer hydroxychloroquine, then sulfasalazine, then methotrexate. And if it is moderate or high disease, prefer methotrexate over them. Next, biological DMARD or targeted synthetic DMARDs, that means the small molecules. Then methotrexate with non-TNF inhibitor biological DMARD, or alternatively targeted synthetic DMARD. So 3 grades of treatment could be instituted in moderate and high disease. Now suppose they are non-responders and they are moderate or severe disease, then what? Guideline number 3, combination of conventional synthetic drugs, as I was talking about, go for dual therapy or triple therapy. Targeted synthetic with or without methotrexate. Methotrexate becomes so very much important in combination therapy because the resistance to the drug does not develop if methotrexate is combined together. Leflunomide and alternatively TNF inhibitor with or without methotrexate, and again alternatively non-TNF inhibitor with or without methotrexate. Guideline number 4. Now here there may be a patient who had exposure to conventional synthetic DMARD, but methotrexate has never been used. So here is one case where there again is a moderate to high disease activity. Prefer methotrexate if it was not used, and prefer it over combination with biological DMARD or targeted synthetic DMARD. And as I was talking about, adjuvant anti-inflammatory, and the best anti-inflammatory is glucocorticoid. So this guideline number 5 is on initial conventional synthetic DMARD therapy. First, prefer not to use glucocorticoid, but it can be used on initiating or changing the conventional synthetic DMARDs. Number 2, initiate short term, that is less than 3 months glucocorticoid, especially if there has been rheumatoid arthritis disease flare. Number 3, you can still use it for long term, that is more than 3 months, if you have moderate or high RA disease activity, there is DMARD failure or biological failure. There is an addendum to the IOA guideline number 5 regarding glucocorticoid that provide best benefit risk ratio for the patient. So use of glucocorticoid should be for lowest possible dose and shortest possible duration. For the risk of long-term glucocorticoid therapy, use acceptable glucocorticoid dose, and the risk of harm generally is very low at long-term doses of 5 milligram or less of prednisolone per day. Taper glucocorticoid as rapidly as feasible. Friends, on a personal note, I would like to say that prednisolone is thought to be the gold standard glucocorticoid, but in my own personal preference, I have treated my patients with continued use of deflazacort with equally good results. So friends, to summarize, the dictum is go low, go slow from early use of DMARDs, from pyramid approach of DMARD monotherapy to step up towards combination therapy and treatment targeted tight strategy. But now there are times when there is no step up. This is an inverse pyramid approach, step down from the top and go to the combination therapy. Friends, what is the future? We all always say there is no cure for rheumatoid arthritis. But here I said, if we can achieve sustained drug-free remission, hopefully in future this will offer a cure, because by then we will have understood the various pathways behind initiation and perturbation of immune regulation. New targeted intervention at individual patient level will influence mechanisms driving occurrence of sustained drug-free remission. So friends, let's look into the future, which may be little too far off, when we can say that this is a disease which can be cured. Thank you very much. Now,
Thank you so much.
yes, thank you, Manish. Well, now I call upon Dr. P. Dhansekara Raja from Coimbatore. He will talk on pathodynamics of articular erosions. Well, this topic has specifically been kept on the persistence of Dr. Dilip Mazumdar, who always is very curious to know why, after all, erosions do take place in rheumatoid arthritis. Dr. Raza, please. Sorry, I will stop sharing. Yes.
Good evening, everybody.
Yeah.
Just a second, please. Respected convener of today's evening webinar, Dr. Panak Bhushan, Dr. K.D. Tiwari, and Ja, President of Manish Khanna, and other faculty and delegates. I'm going to talk about pathodynamics of articular erosion. It was quite interesting to go through this topic, and thanks for this opportunity. So, bone erosion, defined as a radiological term that refers to a break in cortical bone with destruction of natural barrier between the extraskeletal tissue and the bone marrow compartments. So basically, there is a break in the cortex and there is a connection between the extraskeletal tissue and the bone marrow compartment. That is called a bone erosion. So bone erosions are usually localized in the joints and entheses of peripheral joint and of the spine. Preferentially, they are located at the bare area of the joint, where there is mineralized cartilage, insertion sites of periarticular ligaments, and overlying areas of tenosynovitis, disc bone surface in intervertebral disc, and overlying periosteum in the vertebra. So bone erosions typically occur in rheumatoid arthritis and also has seen in spondyloarthritis, psoriatic arthritis, ankylosing spondylitis, erosive osteoarthritis, crystal arthropathies, and also in healthy subjects. The image on the middle shows bone erosion in psoriatic arthritis. Figure A shows mouse ear appearance, and figure B shows subchondral erosions in erosive osteoarthritis called Gullwing sign. So this is the typical radiological appearance of a bone erosion in the IP joint in the hand. So this eventually progresses to complete destruction of the articular geometry. Bone erosion is very typical in rheumatoid and is included as a diagnostic criteria. The severity and distribution and multiple peripheral location, multiple peripheral sites is concomitant with the absence of new bone formation. So in other osteoarthritis, we can see new bone formation. In rheumatoid, there is absence, bone erosion associated with absence of new bone formation. The number and size also is variable, and it can predict the severity of a joint damage. And it allows the bone marrow components to participate in the joint destruction and inflammation. So longitudinal studies of the radiographs have shown that if untreated, these bone erosions progresses typically to a joint destruction within 6 months. So you should differentiate between a subchondral cyst from a bone erosion. Subchondral cyst is where there is an area of osteolysis inside the trabecular bone compartment without any signs of cortical bone destruction. But in a bone cyst, there is cortical bone destruction and there is loss of adjacent trabeculae. So how do you differentiate bone erosion from a cortical break? We have seen multiple X-rays where the nutrient artery is going and we can see there is a cortical break. So newer imaging technology have shown that in a quantitative CT, we can see multiple cortical breaks. There are small channels that perforate cortical bone and carry microvessels that bridge the outer synovial membrane to the inner bone marrow. This is normal anatomy. But how do you differentiate it from a bone erosion in rheumatoid? So in bone erosion in rheumatoid, there is bone marrow edema and the MRI. Not only there is a lot of loss of trabecular bone, there is bone marrow edema. And in contrast to the cortical vessels, we can see in the MRI only the cortical vessels. But in rheumatoid, there is loss of adjacent trabeculae and there is bone marrow edema. This is how you differentiate between a cortical break from bone erosion. So this is a radiograph, MRI and CT of a normal patient. You can see the left side radiograph, there is no cortical break. On the right side, in a high resolution quantitative CT, you can see cortical breaks. In the middle, there is a MRI. The MRI does not show any loss of trabeculae or bone marrow edema. This is normal cortical break seen in a healthy individual. But in a rheumatoid, you can see there is a bone marrow edema and the resorption of the trabecular bone, as we see in the middle MRI image. So this is typical of rheumatoid arthritis, and if it is present, it indicates already advanced disease in rheumatoid arthritis. So these high-resolution images, MRI and quantitative CT, not only helps us in clinical diagnosis, they have helped us in understanding the pathomechanics and pathodynamics of bone erosion in rheumatoid. So basically, osteoclasts are the mediators of bone erosion. As orthopedic surgeon, we all know this, and osteoclasts mediate bone erosion. How do they mediate bone erosion in rheumatoid? Because they are exposed to tumor necrosis factor and other cytokines. This leads to stimulation of two essential osteoclastic mediators, mainly macrophage colony stimulating factor 1 and receptor activator of nuclear factor K ligand, rank L. So these are two mediators which cause osteoclast activation. So there is synovitis, release of pro-inflammatory cytokines, rank L and autoantibodies. These cause differentiation of bone resorbing osteoclasts, and subsequently this leads to bone erosions. So what is the trigger for this osteoclast? First is presence of autoimmunity. So in rheumatoid, we know we have autoantibodies. Presence of anti-citrullinated protein antibodies, ACPA, as we already discussed, help in early diagnosis of rheumatoid. The presence of these antibodies will lead to trigger of the osteoclast precursor cells. So once we know there is anti-CCP positive, the bone destruction starts even then. So there is an importance of early intervention in rheumatoid arthritis. So this autoantibodies causes stimulation of osteoclast differentiation, which becomes osteoclast, and this leads to bone erosion. So even in the preclinical phase, we can see these osteoclasts are recruited in the bare area of the joint. They cause bone erosion. In the clinical disease stage, already bone erosion has started. In the established stage, they lead to complete destruction of the joint. So there are two mechanisms of bone erosion. One is called outside-in scenario. The second one was inside-out scenario. Outside-in scenario happens due to synovitis. The synovitis release inflammatory mediators, and these go and stimulate the osteoblast precursors in the joint fluid. These precursors are recruited into the joint fluid. They go and attach to the bare area, and they differentiate into osteoclast, and they cause osteoclast-induced bone resorption. So the circulating inflammatory cytokines, ACPA, causes stimulation as a result of synovitis. Second one is inside-out scenario. So this happens from the bone marrow. The ACPA from the bone marrow stimulates the B cells, and these B cells release precursors, which stimulates the osteoclast differentiation. These osteoclasts migrate to the bare area where the cortex is very thin. Then this leads to cortical breaks. So these are a list of pro-inflammatory cytokines which cause bone erosion: tumor necrosis factor, interleukin-6, macrophage colony stimulating factor, interleukin rankle, interleukin 1, 17, 15, DKK1. So this is a key inhibitor of bone formation. These are the factors which cause, they are pro-osteoclastogenic. They stimulate bone osteoclast differentiation, and they also inhibit bone reformation. So coming to therapeutic interventions available, denosumab causes blockade of rankle using a neutralizing antibody. This slows progression of bone erosion. As orthopedic surgeons, we all use this denosumab in treatment of osteoporosis, but it has a role in rheumatoid as well. It slows the progression of bone erosion, but it does not reduce the inflammation, but definitely it slows the progression of bone erosion. So direct targeting of osteoclasts in rheumatoid protects bone from the consequence of inflammation, even in the absence of inhibition of inflammatory effect. So denosumab could be a potential therapeutic drug in the future. Second, cytotoxic T lymphocyte associated antigen 4, CTL4. The T cells have two function. Both they are pro-inflammatory and they also protective of the bone. They maintain T cell homeostasis. Type 17 T helper cells trigger osteoclastogenesis, but expression of cytotoxic T lymphocyte associated antigen 4 on T cells is particularly regulatory and is a potential signal for blockade of osteoclast differentiation. So this can inhibit the osteoclast. So any immunoglobulin like CTL4 immunoglobulin, abatacept, this blocks T cell co-stimulation and thus blocks inflammation and bone erosion in patients with rheumatoid arthritis. So this can also be used in reducing the incidence of bone erosion in rheumatoid arthritis. So this is a pathway. You can see there is a lot of inflammatory mediators working on osteoclast precursor cells. Particularly, abatacept can directly inhibit osteoclast precursor cell through T cells, and denosumab by inhibiting rankle can prevent bone erosion in rheumatoid arthritis. There are new advances which is happening. Parathyroid hormone has been shown to achieve repair of bone erosion in mouse model by combination with TNF inhibitors. Second thing, antagonist of WNT signal pathway is also one of the strongest bone anabolic pathway. So something like a sclerosin, which can cause rehealing of the bone erosion. These are the two newer approaches we are looking at. So coming to a conclusion, articular bone erosion is a hallmark of rheumatoid arthritis and is relevant for diagnosis, treatment, and monitoring. Newer insights into the pathomechanics are come, and we are able to understand the bone erosion better, and we have changed our perception from a irreversible damage to a dynamic situation where we can stop and reverse it. So we need to treat treatment early in rheumatoid arthritis so that this inflammatory mechanism can be stopped and bone destruction can be reduced. But further insights could facilitate the development of new therapeutic strategies to repair bone erosion. Thank you for your attention.
Thank you very much. Well, you have done thorough justice to the topic, and I feel Dr. Majumdar must be the happiest person who really wanted to know in greater detail the real mechanism how bone erosions do take place. Well, you have rightly said that cells and cytokine, they play critical roles in the development, and they could be endothelial cell, antigen presenting cells, neutrophil, and then synovial fibroblast. Then synovial fibroblast also has a very good role. You have really highlighted the B cell, T cell, and macrophages, and finally the synovial tissue affects the bare area, and the subchondral bone is the seat where the pathology of rheumatoid arthritis is taking place. And osteoblast, chondrocyte, they decrease, whereas osteoclast and synoviocytes, they increase in number. Now, there is one thing that I would only like to say, that in osteoporosis, it is osteoblast dependent and TNF independent. Whereas here in rheumatoid arthritis, this is osteoblast independent, but TNF or immune signal dependent. Well, dendritic cells derived from osteoclast in rheumatoid arthritis are there, and all GM-CSF, MCSF, all you have discussed in greater detail. And cartilage damage in osteoarthritis and rheumatoid arthritis, because they both are common. Signaling scaffold is harboring bioactive matrix components and soluble factors. They interact with embedded chondrocytes, which are released for cartilage degradation. Thank you very much. This was a wonderful talk by you. And now, let me introduce this young, dynamic specialist from Gurugram, Dr. Mohit Arora, who will be speaking on synovial biopsy. Mohit, this is your turn. And let me stop share. Right, Mohit. Mohit, your sound is, you are muted.
Yes, sorry. So thank you, Dr. Jha sir, for giving me an opportunity to speak on synovial biopsy, and good evening to all faculty. Is everybody able to see the slides, right?
Yes, visible and audible. Good.
Yeah. So my topic for today is synovial biopsy. So in this presentation, I will be discussing when to do synovial biopsy, why to do synovial biopsy, on whom to do synovial biopsy, what information do we get by doing synovial biopsy, which joints do we get it from, and how to do synovial biopsies. Now, first of all, when. So basically, it is not indicated routinely, but can be considered when the patient's history, examination, diagnostic investigations do not point to a clear-cut diagnosis. And it can be used for differentiating between rheumatic and non-rheumatic conditions. It can be done for research purposes, specifically in rheumatoid arthritis, to identify potential target for new drugs. Now, it can be also done to improve treatment allocation of specific targeted therapy, as has been discussed by earlier speakers. Then there are certain therapeutic indications like arthroscopic synovectomy or total synovectomies. Synovial biopsy could also be used in patients with established post-COVID arthritis in order to understand the immunopathogenesis of COVID infection and to develop potential target therapies in those patients in future. Now, as for why, so first of all, why it should be done is, as we have already discussed by earlier speakers, it can be used as a tool to classify early undifferentiated arthritis when the patient is in a window period. So this is an article by Andrea Curvo, which says that the role of synovial biopsy in differentiating undifferentiated arthritis evolving to rheumatoid or psoriatic arthritis. So basically, if we diagnose a patient early when he is in a window period, he can have a better clinical outcome. The other reason is to stratify disease severity of patients with rheumatoid arthritis. This is another paper in Arthritis and Rheumatology Journal, which says that number of synovial lining layer macrophages at the baseline positively correlates with 1 year development of bony erosions in hand and feet in patients with established RA, which can only be known post-synovial biopsy. Now, the other reason why it should be done is to identify the predictors of treatment response. So this is another paper by Francis Humby. It says that histopathology and molecular analysis of synovial biopsies in treatment-naive early RA cohort and demonstrated that myeloid synovial pathological groups were strongly correlated with greater response to DMARDs as compared to post-immune or fibroid groups. The other reason why we do it is to define the disease remission. So it has been seen in clinical practice that despite apparent clinical remission, about 60% of the patients have evidence of residual power Doppler ultrasound positive synovitis at ultrasound evaluation, which has been questioned by B. Salim in his article that should imaging be a component of rheumatoid arthritis remission criteria. Hence, the concept of multidimensional remission has been introduced recently, which includes clinical parameters, Doppler ultrasound/MRI, and normalization of synovial infiltrates on whether to stop the treatment for rheumatoid arthritis or to continue. The other reason is to develop new targeted therapies. This paper shows that research on synovial tissue biomarkers, new targeted therapies have been identified, and which are important in developing a more stratified trial design that improve the treatment and decision making. Now, as for who needs synovial biopsy, there are certain groups, sets of patients. Number one is infectious diseases. They present mainly with monoarthritis seen in bacterial, tubercular, fungal, parasitic infections. Sometimes polyarthritic picture can be seen in Whipple's disease and Mycobacterium leprae infection, not common in our orthopedic practice. Then, as spoken earlier, also deposition diseases like crystal arthropathies, ochronosis, hemochromatosis, amyloidosis. Then systemic diseases like sarcoidosis, multicentric reticulohistiocytosis. Then synovial tumors like synovial cell sarcoma, synovial chondrosarcoma, pigmented villonodular synovitis, synovial chondromatosis, lymphoma, metastatic carcinoma, and last but not the least, foreign body arthritis. Now, what information can we get by synovial biopsy? A very common clinical example that we see in clinical practice is tubercular arthritis, where sometimes because of atypical presentation, it becomes necessary for us to do synovial biopsy and culture in the patient, which is required for diagnosis as well as for selecting the right treatment regimen to document the drug resistance. The other example is fungal arthritis like candidiasis, coccidiasis, especially in the settings of immunocompromised states like diabetes, alcoholism, or intravenous drug abusers. Then there are crystal arthropathies where we need to do synovial biopsy and examine under polarizing microscope. Then there are deposition diseases which manifest as monoarthritis like ochronosis and hemochromatosis. Now, from which joint should the synovial biopsy be performed? This is an article by Martin C. Crane. It says that the inflammation in one inflamed joint is generally representative of that in other inflamed joint. Therefore, it is possible to use serial samples from the same joint, selecting either large joints or small joints for the evaluation of anti-rheumatic therapy. Hence, the synovial biopsy can be taken from active joints, and they are generally representative of other joints. Now, synovial biopsy, it's a procedure where the sample of joint lining and synovial membrane is taken. And usually we do synovial fluid examination prior to synovial biopsy. Now, as for how to do it, in case of knee joint, usually done from anterolateral aspect of the knee joint, can be done in hospital or clinic. So under all aseptic precautions and giving local anesthetic, we insert the trocar, and through that we first insert needle attached to syringe, and we, if there is a fluid in the knee joint, we can aspirate that, and then biopsy needle can be inserted and sample can be taken from 5 to 6 sites. Now, techniques of synovial biopsy, the first one as mentioned, needle biopsy, which we call as blind needle biopsy. Now, it has got certain pros and cons. So it has got greater acceptability. It's a simple procedure to do, can be done both in hospital and clinic. It is cost effective. However, it is suited only for large joints and has low sampling success rate. The other one is ultrasound guided biopsy, wherein we use ultrasound to guide the needle into the joint. So it is suitable for large and small joints, and because it is under ultrasound guidance, it has got better sampling success rate than needle biopsy. However, it is slightly expensive. Then the other one is arthroscopic guided biopsy, which is in which we put the arthroscope into the joint and the synovial tissue can be taken under direct supervision. That's why it has got best synovial success rate. It is suitable only for the large joints, and it can be done where therapeutic synovectomy is required or a large sampling tissue is required. Its only drawback is it's little expensive to the patient. Now, sometimes open biopsy has to be done. Example, in case of diffuse pigmented villonodular synovitis, where the joint needs a proper full debridement and total synovectomy. Now, I thereby conclude my presentation by eliciting a few points. Lots of advanced research has been done in synovial tissue over the last few years, and it has now become possible to retrieve synovial tissue samples of good quality. The synovium has been studied at macroscopic, microscopic, and molecular level, as it is an important determinant for understanding of biology of the joint and etiopathogenesis of several joint diseases. Synovial tissue represents the target of many rheumatic and non-rheumatic diseases, and its analysis is crucial for defining treatment strategies and finding new treatment targets. Its analysis also gives an insight into disease progression, helping patient stratification by working as an actionable and mechanistic biomarker. Thus, The pathobiology plays a very important role and holds a promising future along with clinical practice in the management and treatment decision-making process in rheumatology. Thank you so much.
Thank you. Thank you very much. You have done a Herculean task complete by imparting knowledge, multi-directional knowledge. And you have rightly coined a word, that multi-dimensional remission. So multi-dimensional remission visualized through, will you please stop sharing?
Yeah, yes, yes.
Yeah. So multi-dimensional remission is another adage to drug-free remission and permanent remission, right? So you have rightly highlighted the various forms, and next. So single most important indication for which we thought is it will be necessary, but you have given additional indications for synovial biopsy in a patient with chronic inflammatory monoarticular arthritis, as well as very many other conditions. You have talked about all of them. The needle sizes are there. Open surgical biopsy, as you have said, may be required in villonodular synovitis, or maybe in cases of tumor. And you have rightly emphasized that it should be collected from minimum 6 or maybe even more number of sites. Now, Dr. Manish Khanna, who is professor and head of the Department of Orthopedics in his medical college at Lucknow, and is the President Emeritus of Indian Orthopedic Rheumatology Association. And he has many laurels to his credit in the field of orthopedic rheumatology. So he speaks on rheumatic fever, and the subsequent speaker, Dr. Ravi, he speaks on post-streptococcal. Now, there are some similarities between the two. So let first of all, Dr. Manish highlight his paper on rheumatic fever. Manish, please.
Thank you so much, sir.
I will stop share. Yes.
Thank you so much, Dr. Mohit, for a wonderful lecture. I would like to emphasize a very important point to all the young orthopedic surgeons who are listening to this webinar, that for rheumatoid arthritis, for all these seronegative arthritis, please don't try to depend on the synovial biopsies, because the histopathologist is not going to give you a clear-cut diagnosis. Simply some inflammatory tissues are there, so we should not bother. But definitely the synovial biopsies are very important for a lot of the other concern, as was being well spoken by Dr. Mohit. Well, acute rheumatic fever. So everybody would be wondering what acute rheumatic fever, a condition which is being dealt by a pediatrician, by cardiologist, have to do in orthopedics. No, it's not like that actually. Acute rheumatic fever is definitely a delayed sequelae of pharyngitis due to streptococcal pyogens, but sometime in your OPDs, when you are seeing children from 5 years or even 4 years to 15 years of the age, adolescent age group, and trying to work up if this patient is of JRA. In those conditions, yes, if you have a wonderful knowledge about the subject, then it will help you in differentiating and making it up that whether this patient is from rheumatic carditis, rheumatic fever, or rheumatic arthritis, or this is having a more prominent symptom of about the arthritic manifestation of rheumatic fever. So definitely we need to touch on this subject. So it's a very simple subject. I'll try to summarize it in a very simple form. Any throat infection in the children age group, usually sometime it goes away, most of the time rather, but sometime after 28 days, after 3 weeks of time, it may present as a acute rheumatic fever. That means patient is presenting, you definitely is presenting to orthopedic surgeon, it is presenting for the arthritis. If the patient is presenting having a more carditis features, going to cardiologist. So it's just like a thing, you know. Now, this disease has definitely, as we all know, that having a features from arthritis, from cardiac involvement, from brain involvement, from the syndrome chorea. Actually speaking, this condition was being developed, or the Jones criteria to diagnose this was being developed in 1944. But it was again revised and re-revised by American Heart Association in 1992 and 2015. We are just going to see a basic concept about that. So the Jones criteria, the terminology which we already know, we have to try to pick up these patients, whether they are fitting into that category. That means they should have some major criteria, they should have some minor criteria. What are the major criteria? There should be some joint involvement, there should be any cardiac involvement, some subcutaneous nodule. So here the subcutaneous nodule, you have to be very much sure about, you are differentiating the rheumatoid nodules from the subcutaneous nodule here. Erythema Marginatum, skin is the window of many of the rheumatoid conditions. Erythema Marginatum is one of it. Syndromes chorea. And the minor criteria, it's all like, acute flare-up of any arthritis, as we are discussing this for the last 1.5 hours, like CRP is increased, arthralgia, fever, ESR is increased. In the ECG, you may have a prolonged PR interval or leukocytosis. So we need to pick up these patients for which the diagnosis is very important. And for the diagnosis, what the thing is, either you should have a throat culture, or you can have a so titer, which is still being commonly been developed and done. Then plus 2 major criteria, maybe joint or heart, maybe joint or nodule, maybe erythema marginatum or syndrome chorea. If it's erythema marginatum syndrome chorea, they are going to a skin specialist or a pediatrician. If they are coming with a joint and a cardiac involvement or joint subcutaneous nodule, they are coming to us. And if you are trying to differentiate it with a JRA, you need to have a very good knowledge on the subject. So 2 major criteria, or sometime 1 major or 2 minor criteria will do the job. So these 2 major criteria, or 1 major, 1 minor criteria, plus the lab evidence of preceding group A streptococci gas. So it is in a nutshell called as gas, give a diagnosis of a rheumatic fever. For you, it is a rheumatic arthritis. Pathogenesis is very simple, delayed immune response to the infection, which is the culprit for many of the conditions which we are hearing since the evening. And after a latent period of 3 weeks, antibody-induced immunological damage. But this damage is progressing to heart, to joint, to subcutaneous nodule and basal ganglia of the brain. So it's very alarming actually. It's a diffuse inflammatory disease of connective tissue, primarily involving heart, blood vessels, joints, subcutaneous tissue, and CNS. Now, this clinical presentation is very big and very small also. Big in the sense because sometimes some features are there, some are not there. So clinical presentation that is falling short of the major criteria or the minor criteria, still you can't rule it out that the patient is not suffering from ARF. So if you're very lucky, it's very easy to get in. Otherwise, you have a suspected ARF cases. Now, suspected ARF cases has to be managed accordingly, which we'll deal in the later part of the lecture. In uncertain ARF cases, you need a prophylaxis only. That's it. But the workup should be very followed. Now, in 2015, the criteria was being more modified, more intensified in the way that it was being divided into low risk and high risk population. All the factors are still the same. Similarly, they have, let's work out what is the low risk and high risk first. So low risk population is the incidence when the incidence of ARF is 2 or less than 2 per 100,000 school age children, or for any age group, it is less than 1 or equal to 1. For moderate high risk population, the children not clearly from any low risk patients. This 2015 modified criteria does not have much difference. Sometime it is a part of arthritis, polio, monoarthritis. We'll be having a full lecture on that. But majorly, it is the revised criteria still have standing the same part, that is carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodule, and other findings. Now, routine echocardiography or Doppler examination is now recommended for all confirmed and suspected acute rheumatic fever, not for any orthopedic joint reason, but for finding out the murmur. So this was a very confusing picture, which was being produced since decades altogether. If you remember, in 1992, there was a time when it was being said that there is no need to go for any echocardiography examination for any case if you're suspecting ARF, who is not having any clinical manifestation of carditis, who is not having any murmur. Now, if you see this chart, as it goes down, in 2008, the Indian Working Group has firstly pointed out that no, whenever even a clinical carditis is not there, you have to take a help. So we orthopedician now here to catch hold of the disease would need a help of our cardiologist friend or physicians to go for a clinical cardiac examination. Now by 2012, with the New Zealand and Australian guideline, all the medical college physician, it has been recommended, go for echocardiography, even if you're not finding any murmurs with your physician friend, if you're not suspecting any clinical symptom, even then go for it, because there are very silent features. Arthritis part, I'm not going to go much detail, but just pointing on one thing, because we have another lecture on this, that it may be migrating, which we always ask in the history from the patient. If you see a child, idhar se udhar jodo mein dard to nahi ghoom raha, this is a specific condition. Sometime, but it has been seen, it is additive also. So we can't rely on that actually, truly speaking. If a child is coming before 5 years old, it is mainly a cardiac thing which is prominent, not the joint. That is why we see the age from 5 to 15. So migrating, transient, and large joints. Now, carditis, which is not our subject, but we should remember that in 40 to 50% of cases, it has been present. It needed to be picked up with the echo in early conditions, since we are dealing with the early manifestation of rheumatology, rheumatoid arthritis this evening. So we have to consider this. We can't neglect it all. Clinical manifestation from a murmur or cardiomegaly or chest pain is a proper indication, but need not to worry for that. Symptoms chorea, again, it's not cup of tea, but 5 to 10% of the patients may be having a symptom chorea, where the manifestation may be clumsiness, deterioration of handwriting, emotional instability. So it's just really a good clue for the patient to be diagnosed. But remember, these patients are not going to come to us. They're going to a pediatrician. So, but still, you have to take the history, actually speaking. Now, Erythema Marginatum. So skin is the window of orthopedic rheumatology. Orthopedics, bone, joints, and also a knowledge of skin is very important. Erythema Marginatum occur in less than 5% of the cases. It's a unique transient lesion. Why it is called transient? Because when you press it, actually, it pales off. Pale in the center with red regular margin. You can appreciate here a little bit of pale margins, pale center, and the erythema margins are there. And when there is a dark skin, it is sometimes difficult to work it up, and very good, examination modality. Now the COVID is also gone in, that the pink papules or macule, they all go pale under the pressure. So you can do it. Otherwise, we need to ask the parents about this condition. Now, subcutaneous nodule, their sizes variable from P nut to nodule bigger size, again in 10% of cases. So in orthopedic rheumatology, we have this second condition in which we are bothering ourselves with the nodule. One is the rheumatoid and other degenerative condition like Hibbert's nodule. And one is this condition, subcutaneous, where it has got a lot of significance, although it is mainly being seen in the extensor aspect. So that's a good point. And of course, it should be associated with a strong seropositivity, the markers. So age distribution, we are done. Gender is just the same. Lab investigation, again, all confusing. All ESR rays, CRP rays. ASO is the thing which we try to do. And one more is anti-DNase test, which is high. It's not been very commonly being done in the country, but still it is very important, because if this anti-DNase test is present, if ASO is present, it is nothing but actually the blood test to look for the antibodies to a substance or the protein which is produced by the group A streptococci. So if these two things are present, the diagnosis is very much confirmed. So a presentation from all the things have to be differentiated in the OPD, from septic arthritis to viral arthropathy to gouty and pseudo-gout arthritis. But definitely, because of the presence of these very good features, it can be picked up. Carditis, chorea are the other things. Diagnosis, clinical with the preceding infection history with modified Jones criteria. With all these things rise, definitely remember ASO titer should be more than 200, and please make it sure that it is not to be seen. I mean, it can't be seen actually initially. After 3 to 6 weeks, 3 to 4 weeks, it start appearing and become peak and come down by 6 weeks. So again, you have to take the history about the duration about that sore throat history. ECG, prolonged PR interval, is again important. This is the only thing in the orthopedic rheumatology where the ECG has got some role to play. And echo, which is a subject to be dealt with a physician or the radiodiagnostic person, will definitely going to give a good clue. Treatment, nothing very specific. Definitely, we all know benzathine penicillin is a wonderful drug which can be used intramuscularly in these patients. Those in some children, we can go for an oral preparation also for 2-3 times in a day for 10 days of time. Those who are allergic, again, there is this basket of drugs like erythromycin and other drugs which can be used. Definitely, arthritis is the most prominent thing. We all know aspirin is wonderfully acting very well in these patients. But if the cardiac component is there also, then definitely the better choice is not to depend on aspirin, but to add prednisolone or the steroid group of drug. And the suppurative management as usual, and definitely a secondary prevention of the rheumatic fever has to be taken out. That means every 3 to 4 weeks, intramuscular penicillin, 1,200,000 units every week, or the oral preparation has to be administered. So arthritis and fever, chorea, carditis, and all these things feature associated with genetic markers, which are again not very much available, but as the subject is demanding, so we should know that HLA-DRB1 16 is very important for ARF. So a child, a person 5 to 15 years with a history of 28 days or 3 weeks with a joint involvement, which may be migrating, we have a next lecture, with acute markers, with dramatic response to aspirin, with a carditis part, that is a good thing learning for us for this evening to be remembered, and with a good antibiotic prophylaxis, get good care of the disease. Thank you so much for a very patient hearing. Thanks a lot.
Thank you, Professor Manish. So this has been a wonderful presentation, and rest part of post-streptococcal disease will be highlighted by none else than Professor Ravi Sauta from Gurugram. And you have rightly said that the Jones criteria, in spite of so many modifications by the American Cardiology Society, still holds good, and you can look into various percentages of joint involvement, but carditis is more than the joint involvement. So without wasting any other time, may I request Professor Ravi for being with us from the very beginning. He was the first to be present this evening. Professor Ravi Sauta from Gurugram.
Sir, you have to stop sharing, sir.
Yes, please.
Thank you, Dr. Jha, sir, and thank you, Dr. Manish, for making my subject a little easy for me to speak on. I'll be talking on a topic which is basically post-streptococcal arthritis. Just a minute, this needs little. It is already on the verge of. 1 minute, you have to.
Take your time. Get connected once again.
Oh, just the battery is
yes,
low.
I know.
With my laptop. Okay, so I'll be talking about the learning objective today are going to be to identify the etiology, review the presentation of these patients of a reactive arthritis post-streptococcal, to understand how to diagnose this and to describe the differential diagnosis, and also to outline the treatment in the management of these patients.
Right.
The sterile arthritis after bacterial infection due to gastrointestinal or genitourinary tract or respiratory tract infection leading to reactive arthritis. These are various pathogenic organisms which can be culprit for initiating the activity, disease activity in these patients. In 1969, Ahoen et al., they talked of aseptic non-suppurative arthritis following microbial infection, which is site other than the joint itself. Hemolytic streptococcal infection in the tonsillitis or upper respiratory tract, which leads to post-streptococcal reactive arthritis, was originally reported in 1982. The other earlier, it was also thought that reactive arthritis was restricted to HLA-B27 related arthritis associated with spondyloarthritis, which was limited to arthritis involving caused by urogenital, intestinal, or respiratory tract infection. It is also known as Reiter's disease. It was known as earlier Reiter's disease. It is basically a reactive arthritis where there is a joint inflammation, and this is initiated by after the infection, either due to the sexually transmitted gastrointestinal or throat infection. Generally, patients have a seronegative spondyloarthropathy. It is an autoimmune disorder. There is an inflammation, and rheumatoid factor is usually absent in these patients. As far as the pathogenesis is concerned, basically there is a activation because of the T helper cell. Whenever there is any infection due to the pathogenic organism, it gets attached to the major histocompatibility complex at the macrophages, and then the CD cell gets T cell gets active, CD4 and helper cell, T helper cell gets activated, and then if there is a strong binding, it leads to foreign body reaction and B cell gets activated, and B cell activation leads to so-called these gram-negative organisms. They have a liposaccharide wall all around it. That creates a strong immune response and leads to reactive arthritis in these patients. Basically, immune system activation leads to antibody formation, and these antibodies are directed towards the synovial lining. Whenever there is a suspicion of a post-streptococcal arthritis, as already mentioned, that there is an increase in the anti-streptokinase as well as the anti-streptolysin O increase, presence of a tonsillitis may be seen. Tonsillar stimulation classically leads to increase in the CRP levels, blood count, and body temperature, and exaggeration of arthritis in next 24 hours. Chronic recurrent manifestation is seen in about 62% patients. Total throat culture may be positive in about 50% of the patients. 40% of the patients we are unable to demonstrate the history of streptococcal infection. Anticardiolipin antibodies may be seen in infective endocarditis patients, and synovial analysis shows 10 to 50,000 of neutrophils in the synovium. Bacterial component or a DNA components may be seen in synovial fluid. However, when the cultures are initiated, there is no bacteria which can be grown from the synovial fluid. The clinical presentation, basically there can be oligoarthritis where more than 4 joints are involved. They can be acute onset, second and fourth week onset of antecedent infection due to asymmetric oligoarthritis associated with conjunctivitis. There may be uveitis and urethritis in these patients. Generally, symptom may resolve in 6 months to 1 year approximately. When you look at as arthritis may be transient, there can be recurrence in 5 to 15% of the patients. There may be tactilitis, which can be seen in about 40% of the patients, and few of these patients will have a HLA-B27 positive. 2 or more above criteria with arthritic involvement leads to diagnosis of post-streptococcal reactive arthritis. Axial involvement in post-streptococcal arthritis, sacroiliitis is as low as 20%. There can be pain in the large joints, effusion, and there can be classically balanitis enthesitis, which is more common. Balanitis circinata is present. Enthesitis leading to Achilles tendon, patellar tendon, quadriceps tendon, or a plantar tendinitis. And urethritis cervicitis is seen secondary to chlamydial infection. And in men, generally, they may have a urethral discharge, dysuria, prostatitis, or epididymitis. There can be also what is known as keratoderma venerogicum in the few patients. Women may present with dysuria, vaginal discharge, purulent cervicitis, or vaginitis. Cardiac involvement is less than 10% as compared to the rheumatoid arthritis. So these patients where there is a reactive arthritis, bilateral conjunctivitis, which is generally non-infective, anterior uveitis, or succinate balanitis, generally, as they say, these patients cannot see, pee, and climb a tree. So there is a bimodal presentation. Children at the age of 8 to 14 and in the adult between 21 to 40 years of age, acute asymmetric migratory polyarthritis can be seen after the tonsillar infection. There is arthritis in 2 weeks to more, even up to 10 years. There is a non-residual joint damage or a deformity. Axial involvement is less common, and duration of arthritis before it can be labeled as so-called post-streptococcal arthritis may take as much as 2 years to come to conclusion. As far as the differences between these post-streptococcal arthritis and acute rheumatic fevers are concerned, both will have a respiratory or a tonsillar infection, but a large and small joint involvement is classically seen in post-streptococcal arthritis, whereas large joint and a fleeting type of arthritis, which is classical of a rheumatoid ARF symptoms. In acute rheumatic fever, Jones criteria are classically seen. There is a rise of ASO and DNAs in the patients, but there is no carditis in the patients with post-streptococcal reactive arthritis. There is a mild rise in the ESR and CRP markers, whereas there is very high levels of ESR and CRP, and also fulfills the Jones criteria as described by Dr. Manish earlier in his talk, where there is arthritis, carditis, chorea, and skin rashes. Basically, these patients, according to the American Heart Association, 1 year of prophylaxis antibiotic for the post-streptococcal reactive arthritis is good enough. However, antibiotic prophylaxis for 5 years from the last attack or till 21 years of the age is recommended for patients of acute rheumatic fever. Differential diagnoses are obviously acute rheumatic fever, JRA, Lyme's disease, leukemia, and there are various bacterial or viral infections, gonococcal, gouty arthritis. There can be septic arthritis and various inflammatory disorders which can present. These are comparisons between the classic reactive arthritis, post-streptococcal arthritis. Ponson's disease is basically seen in a patients of a tuberculosis, and there is a non-erosive arthritis. Extra-articular tubercular lesion can be seen in a lung and skin. There can be a tuberculin test which is positive, and erythema nodosum is classically observed in these patients. Generally, ATT treatment is good enough in treating this particular problem, whereas installation of a BCG, which is one of the treatment for a bladder cancer. These patients may present about 4 to 6 weeks, 6 rounds of BCG treatment installation into the bladder leads to arthritis and conjunctivitis. In about 50% of these patients, there may be associated. So this is described as adverse reaction, and usually discontinuation of the therapy is good enough. It suffices to say here that diagnosis of reactive arthritis is clinically based on a history, physical examination. No laboratory study and imaging can help in diagnosis. However, this is a list of various investigations which can be ordered. As far as the PET scan is concerned, sometimes the FDG positive tonsillar fossa can be seen in few of these patients when they are diagnosed for having an infection into the tonsils. American College of Rheumatology has come up with the diagnostic guidelines for a reactive arthritis in 1999. They talked of a major criteria where there is a oligo or monoarthritis involving the lower extremity. Enthesitis and enteritis and urethritis may be seen or a preceding 3 days to 6 weeks before the infection in the before the arthritis in the joint. Major triggering, minor criteria are basically triggering infection, which can be culture positive as it can be grown from the tonsils, and the presence of a persistent synovial involvement. There is a combination of a genitourinary symptom, metatarsophlangeal joint involvement. There can be raised CRP and a positive HLA-B27. Specificity is about 70%, and sensitivity is about 70%, and specificity is about 93%. As far as the treatment is concerned, basically antibacterial drug targeted towards streptococcal should be administered. There is no evidence that antibiotic therapy helps in enterocolitis. Resolution of arthritis occurs once the tonsillectomy is done within 3 weeks. And those patients where their symptoms are severe, they do not respond to NSAID, oral steroids may be indicated. Generally, NSAID for 2 weeks are sufficient. Steroids in patients where there are systemic symptoms, prednisolone in a mild disease about 20 milligram per day, or a 40 milligram in a patients where there are moderate to severe symptoms. If there is a monoarticular involvement, simple use of intraarticular steroid may be helpful. Those patients who do not respond to NSAID generally require sulfasalazine or a methotrexate. DMRDs in a patients with the chronic presentation, those patients who present with symptoms which are more persistent, in these patients, sulfasalazine significantly improves the symptoms. And if methotrexate is a drug which is a surrogate agent for the NSAID, steroid, or sulfasalazine refractory patients. And also those patients of ankylosing spondylitis where there is a peripheral joint involvement, methotrexate has got a role, and TNF inhibitors may be considered in patients of chronic reactive arthritis where there is enthesitis and dactylitis. Usually there is a good resolution in 3 to 4 months. As far as the prognosis is concerned, complete or a near complete remission is seen in about 6 to 12 months after the reaction has been started. After treatment in few of these patients may be required in about 25 to 50% of the cases. Chronic patients may develop signs and symptoms of ankylosing spondylitis or inflammatory bowel disease. And post-streptococcal, there may be few cases where there may be cardiac involvement, which is very, very uncommon. As far as the complications of a reactive arthritis are concerned, there is a recurrence of arthritis, chronic arthritic sacroiliitis, ankylosing spondylitis, urethral stricture, aortic regurgitation, aortitis, or heart blocks. There may be cataract or glaucoma, and so forth. In conclusion, understanding the similarity and dissimilarities between the post-streptococcal reactive arthritis and septic arthritis and ARF is acute rheumatic fever is very important. Differential diagnosis in a classic arthritis, infection-related arthritis includes post-streptococcal arthritis, Ponson's disease, and BCG-induced reactive arthritis. As far as the treatment concerned is tonsillectomy, NSAID, steroids, and sulfasalazine, the mainstay of the drug in treatment. Those patients who are refractory to this, these patients may be started on TNF agents, which may be required for few of these cases. Thank you very much for your attention. If there are questions, you can take up. Sir, you are muted, sir.
So you have given a very exhaustive and detailed discussion of all the corners of the disease. So nothing has been left untouched. And what Dr. Manish Khanna has started, you have gone beyond it in detailing the reactive arthritis. So it is definitely a different entity to acute rheumatic fever. Children between 8 to 14 years of age, and again young adults between 21 to 27 years are affected. It develops within 10 days after a throat infection, and as you have rightly pointed out, apart from large and small joints, the axial skeleton also is involved. So now the topic is open for discussion, and I must admit that BCG induced reactive arthritis also you have mentioned. What will be the difference between BCG induced reactive arthritis and these cases of post-streptococcal reactive arthritis? Yes, Manish has also rejoined. So now the platform is open for our president IORA,
actually,
Dr.
one
Dilip.
minute. What is actually the long-acting penicillin? What is the function of the long-acting penicillin? What is the use?
Yes, Manish?
Yeah.
So it is for the prophylaxis. So basically, penicillin is very good for the streptococcal, and my voice is incorrect. So penicillin is very good for prophylaxis. As we know, it's a good salt, whether injectable or oral, for streptococcus. And the culprit is streptococcal, the mechanism because of the streptococcal and the antibodies formation, and then all the mishappening which is happening is all because of streptococcal. So that is why we require penicillin. It's the most sensitive drug. But it's not the end of the choice. We can have other choices if the person is sensitive to penicillin.
Right.
And you have rightly pointed out that it is to be used for 1 year in cases of acute rheumatic fever, and for 5 years, as Dr. Ravi has said, for his reactive arthritis. One question from my side, actually it has earlier been proposed by Dr. Manish. So for synovial biopsy, he said that this may not be the final say in diagnosis of rheumatoid arthritis. So Mohit, do you agree to this comment, or would you agree to disagree?
Sir, what I've seen in my clinical practice is there is an entity called non-specific synovitis. So sometimes in case of polyarthritis patient who were not responsive during my SRship days, we took the biopsy and a lot of reports came out to be non-specific synovitis. So I think I would agree to disagree that it is not the final end, but I would say by making a presentation on synovial biopsy that it is more for a research purposes and to develop new targets for new drugs. So that is the main purpose.
That is one. I would like to add, you also make a diagnosis that the other things are not there,
Yes.
like maybe tuberculosis, like maybe other
Right.
conditions. So
That is the
way
main reason.
it
It
definitely.
probably
Yes,
That is the main reason. That is the main reason for the biopsy.
Right,
That is the main reason. That is the main reason for the
Professor Dilip. Professor Dilip.
Yeah, actually, Abhay has elaborately told about the prevention for the rheumatoid arthritis and early diagnosis, and identify the various differential diagnosis also, actually to reduce the lesser load of the disease. This is right. He has told also about the window period. So, in the window period, how does it help him to look out for the diagnosis? In the window period, how does it
I
help?
think Dr. Abhay, you are not here, no? Abhay Elhans? No.
He has
So
left.
when he mentioned about window period, the word is window of opportunity. So window of opportunity is created.
Is there any time period or time frame of the disease?
Yes, yes, 3 months.
Within 3 months.
Within 3 months, if you are able to say that yes, this is a pre-rheumatic disease, and in fact, the clinical features are not demonstrable, but still if you can pinpoint that this is one of the early detected.
And important thing is that RA mimickers, he has also
Right.
told about the RA mimickers will also confuse the diagnosis
Sure.
in the window period. That is also important thing that he has pointed out. Next, coming to your Yogesh Kamath has very elaborately and beautifully pictorially, he has actually told us about the confusion also. Very impressive way of presentation. I love it, Yogesh Kamath. That Yogesh Kamath has that confusion that we have in the early diagnosis sometimes very beautifully he has portrayed with 2-3 slides. So, I want to know that the gouty arthritis where there is tophi has not formed. So, how will you proceed for the diagnosis? Very nicely he has told about the polarized microscopy, nice, very nice. But where the tophi has been not formed, how can you go for clinical diagnosis?
As far as clinical diagnosis is concerned, first, symptomatic or not symptomatic, definitely the patient that you are talking about has started giving you symptoms. Now you have to differentiate it with maybe rheumatoid arthritis or various other conditions leading to polyarthritis. So I have talked about two things. Number one, dual energy CT scan and the clinically visible tophi, if they are not there, they are visible in the double energy CT scan. This is one. In a large joint like a knee joint, an experienced ultrasonologist is able to demonstrate the double track sign that I have talked about.
Yeah, that is very clear. Yeah.
Yes.
But that is a late development, early science, because we are actually whole story today is of the early diagnosis.
Yogesh has very rightly said that many a times during acute episodes, the serum uric acid level will not be raised.
Yeah, repeated serology, repeated serum uric acid has to be done.
Right.
That he has stressed.
He also highlighted that treatment with allopurinol or flavoxostat should not be started when there is a time of war. They are drugs of Cold War. So when there are no symptoms, then only you use them. Otherwise, they will provide you acute flares.
Very nice. Drugs of Cold War. Yeah. So that is there. So he is not here. So we will go to your SS. Yeah, Amarnath. Amarnath has neuromuscular symptoms. He has told about from various neurological problems. This myopathy, muscle atrophy, mainly muscle atrophy and altered sensory loss, and even osteomalacia. And how much the osteomalacia is coming into the play, because osteomalacia cannot develop in a day. Osteomalacia takes a long time to develop. So, how these things are coming in the neuromuscular, that is there to be clarified. And another thing is that the fatigability is a very important test in the clinical diagnosis he has told, and there are various drugs also. So, that is a holistic approach has been suggested by him. So, and other things like muscle grading, DTR and serum enzymes and all that. So, what is important in do you get these neuromuscular symptoms in the early stage of the rheumatoid arthritis, or it occurs late stage to confuse us?
This may be late stage, but the whole aim to keep this presentation was only to highlight that neurological symptoms may be the first symptom to make their appearance, but it may be connected to rheumatology. And as I told you, that young patient getting hemiplegia, you may have things like SLE and all other conditions.
Yeah.
And all of us are aware that
Yeah.
soft tissue rheumatism, you keep on getting carpal tunnel syndrome and all other ulnar nerve tunnel syndrome and other nerve syndromes.
Right. So, in the rheumatism, that soft rheumatism that he has told, is there any significance of the skin examination?
Oh, Dr. Manish, he has overemphasized that
That
skin
is
is
right.
the
Yeah.
mirror. Dr. Manish, please.
Skin is the mirror that I know. So,
No,
in
let
neuromuscular,
Manish throw some light on this.
Right,
Yes,
right.
skin is definitely very important, and we have to be very careful. And it's very easily accessible. Only the thing is, we need to ask the patient because there are some hidden areas where you have to work it up. Maybe it's psoriatic arthritis or umbilical may be involved, or nape of neck is involved. But definitely, one should remember what we are talking about. See, when we are talking to the patient, already a diagnosis, some differential diagnoses are there in our mind. So in that direction, if we move, then definitely we're going to ask. It is what
Right,
we are
right.
discussing is actually the early things just to
Yeah.
be taken off.
So, skin is the window.
Yes, and you have to frame your questions in such a way, like Manish has said about psoriasis. There may not be skin lesions in the exposed area. So you have to ask it, is there a patch around the navi or around the anus or behind the ears in the scalp? And then the patient will say, yes, doctor, there are itching areas.
See, this skin informations is there, already there in other cases.
Right.
But I was asking to Amarnath that whether the rheumatism that he has told about the neuromuscular weakness or neuromuscular atrophy and all this thing, is there anything to do with the skin or not? That was my question I framed.
No, skin
Nothing to do with the skin, sir.
Nothing to do with the skin. That is the thing.
No,
Yeah.
no.
Other things we know in psoriasis and all other.
Right.
Erythema or pustula, anything that is the color changes.
Neuromuscular will be
Okay, but
neuromuscular.
Professor Jha, I understood it. You have told about the window opportunity, early window opportunity, and the drugs, various drugs, anti-NSAID and anti-rheumatoid drugs, divided into two groups. But what the actually this IOA guidelines? IOA guidelines is very important. There
Yes.
are five guidelines you have done.
Yes.
Guideline 1, guideline 2, guideline 3, guideline 4, guideline 5.
And
So
there
the
is an
IOA
addendum to guideline 5 also.
yeah, this IOA guidelines are very informative and very useful. So, how do you actually assimilate these things? Because there are sometimes there are actually overlapping. There is no thing like that. This is a water tight compartment like that. It is one is actually overlapping the other. Another is also overlapping
Number
the
one,
other action.
the basis is number one is low disease activity.
Low disease activity.
Yes. Number two is moderate or severe. They are
Right.
both grouped under one. And then number three is resistant cases, non-responders.
Non-responders, yeah.
Non-responders. And number four is all these three we were talking about NSAID naive patients. Now, number four is for those categories where
NAIVE.
yes, naive,
Yeah.
yes. And number four is for those where methotrexate has not been given to the patient, but sulfasalazine, hydroxychloroquine, etc. has been given. And number five is for steroids. Steroids, we have to know short term, long term.
Yeah.
And the dose should be around 5 milligram or maybe even low.
And also, sir, Dr. Jha, if I can add,
Please.
now after listening to Dr. Raja's talk, another addendum may be needed to be added about Brismab and role of, in prevention of erosions and also improving the quality of life in these patients because of osteoporosis.
You have highlighted a very important point. But I will say
Denosumab.
there is an associated, no, there is an associated osteoporosis as well with rheumatoid arthritis.
Yes, sir.
So when you are treating rheumatoid arthritis, you have to look into associated features.
Right.
And definitely denosumab could be a good instrument.
If the disease will go in the remission, the disease is settling down, definitely that portion will be taken care of. There will no need to add a denosumab in that case, actually.
Okay, thank you for adding that. And lastly, I must thank that he has highlighted on the sustained drug-free remission future. Thank you, Professor Jha.
Yes.
Thank you, Professor Jha, for that. That
In
you have
fact,
highlighted.
remission is so multi-dimensional. So it will be very difficult to pronounce before getting it that how many patients have really gone into remission.
Actually,
the basic definition of remission is there may be swelling in one joint, residual swelling in one joint, and still you start calling it remission, which may be a transient remission. And then there is sustained remission, then there is drug-free sustained remission, and then there is permanent remission.
Thank you, thank you. So, Dhansekhar Raja, you see, pseudogouts, and it's how the bone erosion, not pseudogouts, it is the pathomechanics of the articular cartilage damage that was my interest. So, bone erosion in the X-ray, very nicely he has shown about how the bone is eroded in rheumatoid arthritis and gouty arthritis. So, something is actually multiple this new bone formation that will be there in one, and one there will be erosions. So, that is taken. But what are the newer imaging procedures that can tell us about the erosion early? Because we are, our theme is the early diagnosis. So, before the diagnosis early, before the erosion, how can you diagnose early? He has told about the two things, one is outside, one is inside. What is outside? Outside is the synovial that actually trigger.
No, he said outside in and inside
outside
out.
in and inside out. So,
Right.
the main basis was the synovial trigger.
Right.
That was the actually stimulating the osteoclast. Whereas, the bone marrow stimulant that is also being doing this indirect way of osteoclast activity. So, these two are actually combined together or they are one after another. One is taking 6 weeks, another taking up there, or they are combinedly together working together. That I want to know, because
It is
many of
sometimes having a both the things all together. Sometimes one portion is more, synovial portion more, and then the bilateral portion comes out. Sometimes it is out. There's no specific actually.
Bone marrow edema, how can you see that? It can be seen by the MRI.
Exactly.
It can be seen by the MRI. So, early diagnosis, suppose there is a hip pain, somebody, in my case also, I have seen in my practice also, one young this boy, 4th year MBBS, came with the hip pain. So, I diagnosed it that it is early rheumatoid arthritis. He went to a rheumatologist, he did an MRI and then found out the marrow edema and immediately started the steroid. Is it correct?
So marrow edema most of the time in the hip region goes not for the arthritis, goes for the avian, actually speaking,
Right.
unless and until the articular region is involved. And secondly, the synovial hypertrophy is the indication, earliest indication, ultrasonic examination of the peripheral joint is the earliest way to pick up the rheumatoid or seronegative cases of fingers or
Yeah. So, he has pointed out very nicely denosumab. Denosumab we are very fond of, orthopedic surgeons we use denosumab. It is costly, but we use it. It's in rheumatoid arthritis he has highlighted, and that is
Professor Dilip. Professor Dilip, you
Yeah.
were talking about any other earlier investigation. And now it is more than 10 years that role of ultrasound has been overemphasized in diagnosis of rheumatoid arthritis and early changes, and there also erosions can be seen. There was one investigation regarding which Dr. Raja was talking about, and that was something like T3, some T3 evaluation. So we will have to look into what is that T3 evaluation. And
Raja.
Mohit, do you feel while you are performing a biopsy, you will prefer an ultrasound guided biopsy or what?
Synovial biopsy, that is another question.
Definitely, sir. Ultrasound guided should be preferred because we don't, in this today's age, blind needle biopsy is not giving any justice to the patient. Ultrasound facilities are available.
No, we are coming to the synovial biopsy, Professor Jha. There is parathormone. The parathormone and other hormones has got also the role in case of this articular erosion. That he has told. So whether we should give PTH or not in this patient, because nowadays there are parathormone, this inhaler or something like that, they have brought out in the, yeah, they have brought out. Is it necessary for that early stage? Early stage.
There's no need.
No.
There's no need, sir.
Very good. So now coming
and even when you have decided in any case for that matter, even for osteoporosis, that teriparatide has to be given, you have to first investigate the patient.
Right.
Look into parathormone level first. Look into serum calcium. Look into serum alkaline phosphatase.
Vitamin D.
Vitamin D.
D3.
And more importantly, EGFR, glomerular filtration rate.
EGFR, right. EGFR is very important, yeah.
Right.
So our this Mohit Arora, he has newly has come, but he has very much, I am very much interested and impressed about the type of presentation he has done.
Yes.
You see, when, why, whom, what.
So
and
no W except WHO has been.
And which joints, how, what is the technique. These are the things actually this impressed me very much, and this is very quick way to convince people, the targeted audience.
So we pronounce him as the man of the evening. Do you agree?
We pronounce that I as a president I can announce, I have got the power to announce you as the man of the evening.
And you invite him to Calcutta.
The way you have actually this presentation, yeah. I love to see this presentation very nicely. Contents are very good. Synovial biopsy, how can you do needle biopsy, size of the needle, SG guided, arthroscopy guided, open biopsy, everything have done. And also told that who will do the biopsy. My postgraduate student will do the biopsy, or assistant professor will do the biopsy, or I myself will do the biopsy. Very nice. Thank you very much, the man of the match. And advance also you have told about the synovium is undertaking the analysis for the biomarkers, very nice. So, and the future also you have told about that how much importance it will have.
Manish, you have to propose a vote of thanks. Lady Tiwari has not arrived.
And you see rheumatic fever, you see Manish is wonderful because he has taken out the Jones criteria who was left out long ago. As actually he has got an exhumation of that. From the throat infection going to, because my teacher used to tell about the culprit of all rheumatism is the throat infection. I don't know, did not know about 40 years ago, 44 years ago.
And even during those days, auto vaccine
was being built, and that Subir Dutt's laboratory was there, and Subir Dutt died recently. And
we were doing it in
long time.
Right.
Yeah, long time we used to give 7-8 injections of auto vaccine.
Sure.
With those rheumatism, non-articular rheumatism cases. That is wonderful actually, this culture sensitivity. It is simplified, he has round about the treatment. So, I am very much actually, and he has cautioned, he has cautioned about the cardiologist, because always take your cardiologist friend. You do not know what will happen. So, that is why the cardiac problem is there, and the arthritis problem will be associated with that. Then you must send for go around for the cardiologist. And endocardiography, he has known about the routine endography was lost before, but again has revived after 2008. It was actually refused to do. But
So
now,
great
yes,
learning exercise.
great learning exercise, and recently 2015 onwards, again echocardiogram small. What doctor, you are sending for echocardiogram small child? Well, yes, sir. Echocardiogram is required for the small child. That has been highlighted by Manish. That we should be actually grateful to him. And Manish Khanna also told about the 21 to 28 years to keep eye on that patient. Why? Why 21 to 28 years to keep eye on the patient? 21 years of age. And that child would have forgotten about this septic arthritis or tonsillectomy has been done, everything is over. But why you should follow up the patient? Nobody will come.
Many a times there is a very long gap in reappearance of symptoms, and when you go into the detailed history, they will say, oh, ये छोटा बच्चा था तो उस समय इसको ऐसा ऐसा हुआ था. So that
everybody forgotten. So forgotten history has come into revive its play again. So खेला होबे मतलब ये खेला हो रहा है. So in Ravi Sahotra, you see Ravi Sahuta. Achha, Ravi Sahuta, the post sequel is wonderful. He has covered everything, I think.
Yes.
It's actually really you have told him, you have congratulated him. How does this thing, this streptococcal arthritis has gone a long way, and even though you do the culture sensitivity of the synovial fluid, you may not come to the conclusion. But this arthritis is actually transient, that is why. Why the arthritis is transient, we do not know. So, pain in the large joint, pain in the small joint, urethritis or urethral discharge or balanitis, and all these things he has covered up very nicely. But one thing that I actually
so he gives us a signal.
He gives
that
us a
not
signal.
so much skin, but urogenital symptoms are also very important.
Yeah, and major criteria, minor criteria also there.
Yes.
So these major criteria, minor criteria, and there is a diagnosis to be no lab, no radiology, no serology will help. This is wonderful. You see, he has explicitly told about the differential diagnosis of various infection and inflammation of the body. So 4 to 6 rounds of the BCG, this BCG thing I could not follow. What the BCG is? BCG is long forgotten. But
no. Hear from the horse's mouth.
Yeah,
Professor Ravi.
That actually I could not understand how the BCG is coming around again and again.
In patients of a CA bladder, the treatment is installation of a BCG into the bladder.
Right.
And when it is instilled 4 or 5 or 6 times, after that there is a reactive arthritis which is seen in few of these patients.
Yeah.
And that reactivation can cause similar symptoms like conjunctivitis, arthritis and urethritis, and also inflammation in different sites in these patients. And then the indication for stopping this type of a therapy is the remedy, and these patients can also start it with little bit of anti-NSAIDs and steroids.
NSAID and steroid,
Right.
So thank you all of our golden speakers and the man of the match. We must invite all of them to come to Calcutta for the conference of
so
the
you have
IOA.
to first of all tell them what is going to be held in Calcutta.
In Calcutta, there will be the Indian Rheumatology Orthopedic Association conference. Along with that, it is actually our biennial. Manish will tell you about what is going on, because it is in the form of an international conference. Manish, would you tell that?
Thank you so much.
So now it is the turn of Dr. Manish Khanna to propose a vote of thanks also, and his concluding remarks.
First, he will tell about the Calcutta.
Thank you so much, sir, for a wonderful evening and a wonderful conference. And definitely, we all orthopedic surgeons must have appreciated how important is to have these small topics kept in our mind, small points kept in our mind for diagnosing early arthritis.
We also must invite Naveen also.
Yeah, definitely,
Yes,
definitely.
yes, yes, sure,
Definitely,
sure.
definitely.
Yes, yes, sure, sure.
So thank you so much for all the inputs from all the speakers. And we will be having a biennial conference that is yet to be biennial as an international conference from this year onwards. And that will be having international faculty also taking lectures and orations. Many of them are going to be joining online, and this would be in Calcutta this next June. From this year onward, we'll be making this conference as a 3-day program. The first day, we'll be trying to have some workshop, and second, third day, orations and the other guest lectures and all the specific lectures topic, along with some regenerative topics of orthobiologics related to joints, bone joints. So I'd like to invite everybody to this, all the audience who are here, the young students, the orthopedic surgeons. And Dr. Mohit Arora, you had done a wonderful job this evening. I would like to invite you as a member also of the association.
Yeah, yeah.
So that, because gradually we are moving ahead as surgeons. There is a big gap between medical and the surgical management. That is a vacuum which was trying to be finished with the orthopedic rheumatology, at which place we need to place our knife on the joint when the treatment is not in actually. So with this orthopedic rheumatology teaching and the forum and the association and the textbook and the journals, we have got index journal also. So we are trying to fulfill and minimize this gap to negligible zero level.
Ramesh must tell about the first book. That is important. First book of rheumatoid.
So first book of I think everybody knows. I'm just appreciating a lot by all the young orthopedic surgeons. This textbook of orthopedic rheumatology. You can buy it from Amazon. The only book available in the globe subjective on the subjects of orthopedic rheumatology. From medical point of view, surgical point of view means those points which are really being missed by us. Maybe soft tissue correction of the wrist, fingers, which is early modality for diagnosing also with the biopsy, as well as establishing the correction part in the joint, plus the stem cell portion, the regenerative science portion. So anybody can buy for it. Thank you so much, sir.
Thank you, Thomas, and I owe to everybody that for a wonderful job that you have done.
Thank you so much, Dr. Jha sir.
Under the abnormal Jha Sahab will get all the credit because the way Jha Sahab was helping in servicing small portion at the end was really wonderful. I really wonder, excellent, because he has prepared this slide before. I cannot prepare this slide immediately. That is why I wrote it only.
Sir, you have also pointed out very important things. The discussion was very interesting.
So,
thank you.
So your Thanksgiving has to include his name first.
No. The most important thing,
you should thank Naveen. Because I am using his laptop.
Definitely IOA platform.
Apple laptop I am using. His Apple laptop I am using.
IOA platform is very important. I think we had our first subspecialty meeting in 2010 at Jaipur. And then with the vaccine planning, sometime we are not having it for the last 2 years now. It's a subspecialty which is very important, and I think everybody can appreciate, all the trauma persons also can appreciate. Because sometimes, as for my topic is concerned, at GRA, I'm treating a patient with a fractured femur. And even after treating the patient for 2 months with spike or surgical intervention, gradually the parents may be coming to us, the joint pain. So again, I need to take that history of streptococcus infection. So everything is in the loop. So for a perfect orthopedic surgeon, you have to be A to Z.
A to Z.
Thank you so much, sir. Thank you so
and that is there in the book. That everything is there in the book also.
Yeah, it is there in the book also.
So thank you very much.
Thank you so much, Dr. Mohit,
Actually,
Dr. Naveen Thakkar, and our president.
Everybody is a wonderful soul. So I am indebted to everybody. Thank you
so
very
much. Thank you so much.
Okay, and Ravi Sauta, he is one person who came in the very first minute, 3:30. Before 3:30, he was present.
You must give special thanks to him. Yeah.
All right.
How sincere.
Thank you so much, Dr. Ravi.
He has got a love for us. Thank you.
Thank you. We again want to say to everybody to be a member or really want to learn orthopedic rheumatology, because it is again catering 50, more than 50% of the patient which we are seeing. All the trauma, beside trauma, everything it is in it.
Right. So
Thank you so much.
glory will be increased higher up.
With the
And,
blessings.
Thank you. Thank you.
and Dr. Dilip, you are staying with Dr. Naveen.
Yeah.
Please
Naveen is
also-
here with me.
Okay.
And I'm using his laptop.
No. Is he there?
Yeah,
right
he is
now?
there. He will show your face just now.
No,
He will
is
show
he?
the face.
Is he
Yes,
there?
I am in his room.
Okay. Is he there now?
Yeah, he will come and give you thanks also.
Okay.
Yeah.
Good to see you.
Yes, sir.
Okay.
Thank you. Thank you. Bye, sir.
Let me tell you that we have proposed an IOA guideline for treatment of early rheumatoid arthritis today in this meeting.
Very good, sir.
Earlier, you must be knowing that we have a proposed and a defined guideline for spondyloarthropathy.
Yes,
So
sir.
the record has been made straight today by proposing
Thank
IOA.
you, sir. Thank you, sir. Another feeder in with your sir.
Okay.
Yes.
With
Thanks.
everybody's
Thanks
support.
for such an academic feast. Now we are in the queue. We are in the queue to join with the same Zoom meeting with the PG teaching.
I know.
All
Please go
faculties
ahead.
are in the queue.
With,
Yeah.
with warm
Thank you,
regards
sir.
and best wishes. All the
Thank
best.
you. Thank you.
Thank you, everybody. Bye. Bye.
Thank you. Thank you, Dr. Yogesh ji, Ravi Sauta, and Dr. Khanna, sir. Thank you.
Thank you so much.
एक मिनट Dr. Dilip Majbood, Dr. Dilip ji wants to say something. Yeah.
Yes.
So, Dr. Jha Sahab,
Yes,
are you
sir.
happy today?
Oh yes, you conducted it so
And,
well in the end. You conducted it so well in the end.
No.
You
Actually, I
you
came
could jot
running.
down. You could jot down all the points.
Yeah.
Very relevant.
Yeah.
Very good.
I have all the points I have jotted down.
Keep them as record.
It was very impressive of him.
Right.
Everybody's talk is here.
After all, you are the president of the association.
Yeah, I have to do the justice.
If I
of my
remember the
chair.
dates correctly, the dates of the conference are 18th and 19th of June.
Yeah, you should come one day before.
Okay, we will do that. Okay. रवि जी आप भी आएंगे इस कॉन्फ्रेंस में वहाँ कलकत्ता में
हाँ जरूर
18th
please आइएगा
19th June.
You will love to enjoy that.
Okay.
Lovely thing.
Okay, all the best.
It is. It will be full of
Everybody is
love.
getting delayed. Thank you.
Thank you very much.
Thank you, sir.
Thank you. देखा हाँ थैंक यू तुम्हारा लैपटॉप इतना बढ़िया काम किया ना